figured I would make a quick introduction. We talked about Dr. Palmaz earlier. Everybody knows here is the inventor of the Palmaz stent. He was our plenary speaker in 2009 when we started this course off. It has dawned on me that this whole conversation today and this afternoon was really based on an invention that Julio came up with in 1988? 78. So I want to read a little bit just so y'all know the presence of whom y'all are sitting with. So Julio got his MD in 1971, the National University of La Plata in Argentina. He trained at the University of California, Davis, and in 1983 joined the University of Texas Health Science Center as a chief of angiography and special procedures. We'll talk about this in a minute, but he made an observation when Dr. Grunzig had invented the balloon catheter to dilate coronary arteries. And my infamous claim to fame to all this is that I was a resident at Emory with Dr. Grunzig on Dr. Hurst's service. I probably, again, have the infamous claim of saying that we told Dr. Grunzig goodbye when he got into his plane on that Friday afternoon in October of, I believe, 1985. He said he was going down to Sea Island to spend the weekend, but he would be back at Emory on Monday morning to do cardiology grand rounds. And when we showed up in the room on the fourth floor at Emory, and 7 o'clock on Monday morning, there was an empty podium with 3 or 4 patients on the table, and Dr. Grunzig never showed up. And he was killed in a plane crash, as everybody knows, in 1985 in South Georgia. Before that, however, as I think everybody knows, he had invented this thing called coronary angioplasty. Dr. Palmaz made some observations about what was going to maybe happen when you put a balloon in a coronary and you dilated a very fragile tissue, and that led to a success story that we'll hear about in a second. That eventually led to him issuing 62 patents, authoring 36 books and book chapters, was eventually inducted as a fellow of the American Institute of Medical and Biomedical Engineering. He was inducted in the Society of Interventional Radiology. His invention of the coronary stent is on display in the Smithsonian National Museum of American History in Washington, and he has been anointed as a distinguished scientist of the American Heart Association. It was inducted in the National Inventors Hall of Fame in 2006, and the National Academy of Inventors in 2013, which I'm not an inventor. I've had a few patents, but I can tell you that those recognitions in the United States are few and far between in people that actually come up with novel ideas. He is a gold medalist in the Society of Interventional Radiology and Cardiovascular Interventional Radiology Society of Europe, and received the Fritz and Dolores Russ Prize from the National Academy of Engineering in 2019. So that gives you a little bit of an idea of what his contribution to the world and to our world has led over the years. So what we talked about this yesterday. We said, well, we could just speak about innovation in the world of cardiology, but for those of you who've not heard the lecture through the course of this meeting, we thought it might be fun to just go and figure out, how do you kind of do that? Who comes with that? Who comes up with that idea? You're sitting here, so tell us, Julio, you saw an angiogram or you saw an example of coronary intervention and had an idea? That's how this started?
Well, I essentially at that time I was 32, and it was pretty old already to, I started a career at that time in the U.S. And definitely I didn't have too long. I had one thing. I had determination. I knew that I was going to do something, and I was just looking for the opportunity. And definitely I went to my first vascular meeting, and Grunzig was there, the speaker. He was a young guy. He probably was as old as I was then. Looked very young to me. And
Now, this
and
was what year do you think? This was
that was 78, February 78. And that was 4 months after he did his first angioplasty. He presented 4 patients with coronary angioplasties and 2 autopsies out of those 4 patients. He was incredibly honest about this being a thing that needed a lot of work, and actually spent more time talking about his foot-operated balloon inflating device, which was inflated with gas, rather than talking about the technique, about how he made the balloon, and everything related to the procedure itself. But the guy was definitely honest, and he went over all these few slides of the pathology of the abrupt closure that led to the patient's demise, and he was very sober about it. And anybody with a mechanical mind at that time, would have come up with the idea of using a metallic scaffold, and and I was there. I had the motivation, and I was very attentive, and I comment the idea to my chairman, who picked me up on the way to the airport, and he said, well, write this up, and I did. I wrote it up as a report, and interestingly enough, that report became essentially the basis for me establishing the inventionship, because many years later we were, it was challenged in court.
But that got you a date. Right,
and I got my date, date of invention because of that. With drawings and everything, you were all theoretical.
Now, Gianturco and Rubin were coming along parallel at this point with the Gianturco-Rubin stent, or was that a little bit down the road?
Well, I was pretty isolated, so I don't know what really other people were doing.
Yeah.
My patent dated 1985. The Gianturco-Rubin patents were dated 87. I think they were coming a couple of years behind us.
Right.
Yeah.
But yours, as far as IP, because that was just a folded wire. You actually came up. Tell us about that. What was unique? What was
my 85 patent is 665, and actually we describe the wire woven mesh with soldered cross points, and also the slotted stent. At that time, the idea was theoretical, because I have no idea how at that time, essentially when I came up with the concept, how you could make it really. Laser was not invented yet, and well, eventually somebody gave me the idea about how to make it.
Tell us that story.
Well, that essentially, after asking several companies to materialize the idea based on drawings, one company, after rejecting the proposal, he said, go see this fellow named Werner Schultz, who was a biotechnology technician out of Stanford, retired in Willits, California. And the following day, I was in my car, my way to Willits, and met Mr. Vance, and he looked at the drawings and immediately came up with several alternatives how to make it. And then he said, EDM is the most likely one. He said, EDM is widely available, and your design lends itself to use EDM because it's a slotted tube. And and then I asked him if he could help me with that. He said he didn't have an EDM machine. And then essentially he said, go to the Yellow Pages. There is lots of EDM shops out there. I said, wow, after several years of looking for a way to make it, the thing is as simple as looking into the Yellow Pages. And Mr. Werner Schultz, died a week later, so that was it. And that was also my decision to, go look for a place where I could work with this. University of Texas at the time had an EDM machine in campus. And and that was my decision to move from California to Texas, to San Antonio.
That's interesting. So when did the partnership with industry come in? Because you shopped with several potential industry partners.
So we did, we at the University of Texas, we did the first slotted tubes, the straight tube with multiple slots, and we make them in several sizes, including sizes that would be compatible with coronary arteries. It was at that time that I met, Richard Schatz.
Right.
And, he was incredibly encouraging, and in fact, he viewed a big role for the stent. For me, at that point, it was nothing but an interesting project, but he essentially had, a visual about where it could go. And we started working together, and so Richard was working at the Brooke Army Medical Center at the time. So he would come to university. We had an animal lab, and we were,
So this was bringing us into late 80s?
I met Richard in 83. Yeah, mid-83.
And then his contribution of the articulation, was that based on?
Right. So, it was obvious that, by that time I had already done placements in animals, all in straight arteries, even renal placements, but they were possible. It was possible to use a straight stent.
Right.
So, Richard, and I discussed the idea of using two stents, joined by a single connector. I hated the idea because it was, it was to me a way to get restenosis right where the slot, the connector was, and we came up with the idea also to use flexible connectors in a spiral fashion. So, but the limitation to how far you could think was the fact that the EDM was the only possibility, and EDM only made straight cuts. At that time, Johnson & Johnson already had picked up the project, and obviously the engineers loved the idea of the slotted stent. It was easy to make.
So the J&J engineers were starting to contribute to the product at this point.
Right. So in fact, they picked up the same EDM machine I was using, and the first the stents we used in the human trials were actually made by the same guy that did my early prototypes. Yeah.
Now back to the IP though, because there was an interpretation for a long time. I think you explained this at a meeting a few years ago, that the intellectual property was not just putting a stent on a balloon and blowing it up. That the Palmaz IP was really more around these units, around the repeating units.
I mean, all those considerations came up later on in litigation. So we spent 9 years in the U.S. and 3 in Europe and Canada litigating the patent.
Defending.
Yeah, right. Because, for example, there were other balloon expandable stents that were not based on slotted tubes. They were welded wire, that the Medtronic approach. But at that time, Johnson & Johnson owned the stent 100%. That would be the only way they would have gone to litigation if they completely owned the stent, because it was a significant investment for them to, eventually they spent $50 million in litigation back in the 90s. And, the interesting thing, I always thought that that I was essentially the author of the balloon expandable stent. In other words, a stent that was deformed by inflating a balloon that increased the diameter from diameter A to B.
Right.
But turns out that they essentially through all the litigation that went on, what actually prevailed was the so-called Palmaz ring, which is a zigzag made out of malleable metal that goes all the way around the circumference, and only if you open it, then that cannot work anymore as a balloon expandable stent. So they recognized that there was that ring was present in all balloon expandable stents regarding of the design.
No matter the architect, it was the
Right.
same.
So there was always that, and they even gave it a name in court. They called it the Palmaz ring, and so. But at any rate, of course, there was a lot of appeals and going back and forth, and eventually in 2005, the judge presiding all those litigations went for a the final declaration and gave me the authorship of the balloon expandable stent.
So basically applicable to every stent that had subsequently come on the market since then.
Right, and my patent expired that same year. Yeah.
Was there a retroactive payment that had to be settled?
No, at that time I had no financial involvement in the stent, but it was interesting because the litigation altogether took 12 years.
Wow.
Yeah, so I spent a lot of time in court. Yeah, I learned quite a bit about patent law.
Now explain the I think some people have heard about it, the Fuddruckers Association.
Well, Richard had a tremendous role in all of this, and he was first visualizing the potential, casting the idea forward, and then he, on top of that, met the financier of the project, because we knew that without money, these things, I had limited funds at the university, and Richard, of course, working in the military, didn't have that either. And but then he found a restaurant entrepreneur named Philip Romano, and made him enthusiastic about it by being very, persuasive to him that this was going to be a great project. And Philip bought it. He agreed with that, and he was very, very forward. To the point that, his own personal lawyer, who was at our first meeting, was totally discouraged. He said, "Philip, this is crazy. They have nothing." And
this is way before J&J. This is you guys trying to put a company together, funding the company.
This is this is in 1984, and Philip, again, just like Richard, had the feeling, that instinct that great businessmen have, and I was always on the negative approach. Richard and Philip were always very optimistic. And I remember after my first meeting, Romano was rolling a coronary stent in his hand, and he said, "This looks like something I can put in a box and sells for lots of money." And I was just amazed at the things were happening, really.
Yeah, you tell the story. He actually went with you to negotiate with the Bostons and the
right. Once we formed, Philip he said, "I'm going to put money, but I'm going to create a formal partnership," and EGP was created. It was Expandable Grafts Partnership, and so
three of you.
The three of us, yeah. And then we started, going around everywhere. We went to many of the big, companies and presenting the case. And the showstopper was the price tag, because Philip Romano wanted, a price that, would turn red anybody,
The restaurant guy,
right,
setting the price.
Right. And, I always remember the face of Peter Nicholas, the president of Boston Scientific, when he popped the $10 million price tag, and he turned totally red, and he said, "Do you know what you're talking about?" And 10 minutes later, we were on the street waiting for a cab, and but eventually he persisted. He had this idea that we were going to succeed in licensing the stent for his price tag. And eventually Johnson & Johnson came and, pay that price tag.
Who got it in J&J? Was there one person?
Well, it was Richard again. Richard found Johnson & Johnson, his second great find. And,
Was there
Richard, I always told me he had the crystal ball, he could, he had the instinct to, and he knew that Johnson & Johnson at that time had a motivation to get into the vascular system, into the vascular business. They had bought the ultrasound company Technicare, but they wanted to go into something else, something really big. Johnson & Johnson doesn't get into something unless it's important.
Yeah.
And so it was almost like a perfect alignment of the planets. Richard talked to Johnson & Johnson representative, and he came back to visit us in San Antonio. He went smooth as it could be, and next thing you know, we had a licensing agreement.
So it was approved in 91 for peripheral, right? In 93 for coronaries, the eventual.
Yeah. So once we were associated with them, Johnson & Johnson established a small group in Ethicon. That was the pioneer group. It was 7 people, 3 engineers and 3 non-engineers. But so we started planning for the IDE. Interestingly enough, before we did the licensing, already had applied for a peripheral IDE on the first placement, iliac stenting.
Yeah.
And it was already presented at the FDA. And I was essentially I was a solicitor, he said, and so they actually, by the time we did the licensing, the answers of the FDA were already back. 30 days later, the answer with some 90 questions about that. So, then, I had a lot of regulatory help from them, engineering, and we were very, very easily to answer all those questions. So then it went back, eventually got approved, and, but a year later, we were ready to start our IDE in a multi-center format, 10 centers.
So what was that duration of the J&J relationship before approval? 6-8 years? How long did it take to actually get from the idea? How long did it actually take to get to implantation?
Okay, so the licensing was 1986 with them. The patent application was 85. The trial started in 89, and it was finished in somewhere in the mid-90s. We got the approval by the FDA for human use, which was the first vascular stent ever approved by the FDA in 1991. So
yeah,
and then the coronary stent got approved in 94.
Got it. And then drug-eluting technology. Were you guys still? Was that a second chapter, or where were you all?
No. We were totally focused on the engineering aspects at that time, what metals to use. No, I mean the limitations of the stent, which mainly restenosis,
right.
in the coronaries, didn't come up to light until we were in the midst of the clinical trials in the coronary arteries.
Right.
Yeah.
When restenosis started to show itself.
Right. I mean. Remember the biliary stent, the famous biliary stent? Okay, so it was approved by the FDA for use in the biliary ducts, and it was quickly adopted by a lot of people to do all kinds of applications, including cardiac.
Yeah.
And to the point, and it was very successful at the time, and to the point that somebody in the FDA said, look, I mean, you cannot keep pretending that this is going to be another off-label use. You got to make an application, and so we made an application for femoral use and renal use of that particular stent. But the first use actually was in the coronary arteries.
I remember, not to show my age, after finishing at Emory before the generation of stents, and Dr. Kanzeri, probably you may have been involved, or you're a little younger, that these tortuous hours of the stacked perfusion balloon prior to stenting. I think the longest record in the Emory cath lab was 13 hours of leaving a perfusion balloon up in a coronary artery. To Hadley's laughing. You remember those days, and then trying to, and then the stent comes out, and the whole world of cardiology changed.
Well, we have to remember that I mean, it looks so everyday and very natural for anybody to put metal implants. At that time, the idea of putting an implantable metal stent in a permanent fashion was a repulsive idea to just about everybody.
Yeah.
I mean,
particularly in the coronary artery.
I always say the stent had to wait until every modality was tried before they even look into it. Laser, atherectomy, every modality.
Right.
Even balloon was not totally approved at that time. Had really gained consensus, and so let alone placing a metal device in vessels. So it was not that easy. I mean, it took a lot of work and a lot of convincing and waiting it turn.
Everybody had to come up with all the technologies to screw up the artery before they put a stent in it.
Right. Right.
Which is,
I mean, the idea was, I remember at that time, 1983, the darling was laser.
Right.
I mean, everybody dreamed. Even President Reagan endorsed it in his in one,
Yeah, this was it.
His speech, and obviously, I mean, everybody wanted a non-implantable solution. And but trial after trial, I remember they were coming one after the other. The Pelka trial and other ones,
right.
Atherectomy trials at the beginning did not work, and so people would say, okay, next, what's next? That's essentially, the evolution of all these technologies.
Did you ever, looking at this day that you looked at with some of these stenting angiograms of these cases that we've just witnessed that would have been bypass surgery cases, no doubt, years ago, did you ever think that contribution was going to change the way we did intervention like it did?
Sorry,
that your contribution would change the way we do intervention as much as it has?
I mean, look, I mean, I as I said, I always approach everything from a negative viewpoint. Nothing's going to work until proven otherwise. I thought, early on that stent was going to be a specialty item. That was going to use as a last resort, and that something else was going to work, and maybe in complicated cases you will end up using a stent. When we started with, the iliac trial, and then the renal trial, and then the coronary trial, I mean, the adoption was so massive and so enthusiastic. The project really got out of hand.
Yeah.
I mean, I was going to Europe, for example, to do my dog and pony show, lecture and a case, and people were already doing things like outpatient stent placements. It just blew my mind. I mean, they were always ahead of us. Quickly, the medical community not only adopted it, they just developed every possible avenue you could have. I was restricted by protocols. I couldn't do anything, really.
Right. All the off-label expansion is
That's right, and everybody else, Yeah. And then, of course, when I was at home, I was getting the phone calls, at night. Oh, the stent came off the balloon. What do I do now, Yeah.
Well, I think, and they write about this, the fact that you'd put that stent in the artery and it would look like a normal artery.
and cardiologists were like, wow, we fixed this vessel.
Well, yeah, that was, the oculostenotic reflex, a famous, I think it was Eric Topol came up with that name. Yeah, it was seductive. I mean, people would just immediately, you put a stent and everything else would look terrible compared to the stented segment, and you continue putting, until you got it,
Yeah, and you weren't coming back in the middle of the night.
Yeah, well, from Europe, of course it would come in, in their daytime and in the middle of my nighttime, and just to tell me some incredible complication they just had. And
that's fabulous. Does anybody have any question? Any other? The old people in the room. Hadley? Brad?
Well, first of all, Dr. Palmaz, I was just curious some of the tough times you went through. Like, let's say when Benestress and some of about Benestent, when the early stent trials were coming out in the coronaries, they had a lot of vascular complications, bleeding, and things like that.
Can you speak a little bit closer to?
Sure, I'm sorry.
Having trouble hearing you.
So when the early stent trials were coming out, like Benestent and Benestra, you had a lot of vascular complications. Were you discouraged in any way? Were you thinking, is there a better solution to this for the anticoagulation problem?
For the vascular side?
Yeah.
Well, I mean, obviously, all the things that you already know it. I mean, we started trying at the beginning. We didn't figure out, the anticoagulation, regimes, and we had bleeding complications. The sheet sizes were enormous, and then, Colombo came up with the idea that we were expanding the stent by not using enough pressures, but the balloon technology was not developed yet, to the degree that is today. So the stents consistently were under-deployed. And so, and all those things were learned, through trial and mistakes and, and trial again. But eventually we were figuring out things, then came, the antiplatelet therapies and the use of, get rid of the coumadin and dextran that we used, in the early cases. And so bleeding complications were, were pretty prevalent those days, But it's amazing, the community, when they give me credit for the stent, in reality, it was a group development, because everyone came up with something,
Had Grunzig come up with the idea of a stent before he was killed? Do you know?
Not that I don't know.
Yeah.
I really don't know that. I mean, I'm sure that he would have lived longer. He would have probably come up
with something.
Idea of that. Yeah, I was at the right time in the right place, and I acted quickly on it. So that was my advantage.
I was involved with to your maybe also your question, Pratt. I was involved as an expert witness in a lawsuit around a groin closure device years ago, and they had actually discovered a bunch of boxes with Grunzig's drawings from Emory, and he had actually written Angioseal on a piece of paper with his signature, and he had thought about groin closure before his death. And of course, it went on to other iterations with other companies, but he was anticipating the vascular complications.
I was more curious about just your emotional state, like when you saw the ups and downs and such, as with these different outcomes.
What was that?
I was just more curious about his emotional state as the inventor of this, the ups and downs basically of these clinical outcomes. Did you take it personally? Did you look at it more as a curiosity, like when you saw complications, when you saw the successes?
Right. Again, as I said, the trials and many times in the hands of cowboys, they just wanted jump ahead before you go, step by step. One example of them was carotid stenting. I opposed carotid stenting at the very beginning. We used it, carotid and vertebral stenting in cases that, for example, people with radiation stenosis of all 4 vessels that had no other possibilities, then definitely no surgery was possible. Then we will use stenting and with great results. And but I thought that use it in lieu of established technique like carotid endarterectomy at that time, to me, was like, it was not adequate. And so what we did actually have a disagreement with Ruben at the time, because he was very proactive.
Pushing the carotid envelope at the time.
Right.
But the self-expanding wall stent had come out of Europe, right?
Yeah.
Yeah.
Right. Well, it was interesting. I had the opportunity. There was a meeting in Nuremberg, Germany, where Wallstein, the inventor of the wall stent, Gian Turco, and myself, each of us presented the 3 stents, and 3 totally different operating principles. And Wallstein actually was very, very negative. He thought that his idea was the worst. He said, and he's not a physician, but, and he said, we already, came out of this. Sold it to Schneider at that time, and he was into paper, into developing, paper manufacturing.
Oh, that's.
And he was not very optimistic about, that this thing would ever, come up to anything. And definitely the wall stent did have a role at the time.
Right. Any other stent questions? Because I'm going to ask a wine question in a minute.
Julio, thanks again for being with us. And I just wanted you to know, I took a picture of you and Charlie and sent it to Richard. And he said, I was telling him that you were complimentary about his contributions. He said he can't remember that far back. But I had what of all the questions I've always asked you, I have two comments. Well, one comment and then 2 questions. One comment is that I remember Eduardo Sosa telling me that the first time you did procedures that he couldn't believe you just inflated this balloon for 15 seconds and then took it down and took it out. He was used to the stack or the Gordon Anderson perfusion balloon catheter of leaving it up for 10 minutes and you just put this in and then took it out, and he couldn't believe that. My 2 questions for you. First are, this was described as a slotted tube. It was described as expandable grafts. When did the term stent come about, and who was credited with that?
Excellent, yeah. I sent my first paper in 1980 to AJR, American Journal of Röntgenology, and the editor, and I call it at that time BEIG, balloon expandable intraluminal graft, and he didn't like it. He said, no, this should be called a stent. And he didn't give me much of an explanation, so I looked it up in the dictionary, and a stent, he said 2 things. It's a military grade, low grade in the military ranking, and it's also a stick used to hold plants in place like for roses. And I said, okay, well, I assumed that, and then Marty Leon, then later on, came up and said that with a second explanation. He said, a stent is also after the name of this British dentist that invented the paste to take dental impressions. He said that paste became generic in plastic surgery because it was used to hold grafts, skin grafts in place while they were healing. So it became actually a verb. So any device that supports tissues in their healing phase, then is called a stent.
Stent. But it was originally the editor of the American Journal of Radiology? Is that what the journal was?
Yeah, Röntgenology. Yeah, AJR, American Journal of Röntgenology. So
Röntgenology, okay, yeah. AJR.
And then the first paper was published, with the name stent. Yeah.
My second question is that you were describing that you thought this technology would be used as a default for try everything else and then put in a stent.
Right.
And it reminds me of an editorial many years ago that some might remember in circulation by Antonio Colombo about the bioresorbable scaffold that it was fulfilling its promise and then fading away. That was actually the title of his editorial. and when you saw that technology come forward, and it's still going to be revisited, I think, in the next few years with other technologies. But what was your thought about that? Were you enthusiastic? Were you skeptical as before? What are your thoughts?
Eventually I learned a little bit about metals. I became what I call, an amateur physical chemist. So I learned about surface science and metals properties. And, the first thing that we're facing with the idea of placing a stent inside of the vessel is that we didn't know beforehand what kind of resistance we were, going to get opposing the radial expansion. So essentially we had to have something that had a big margin, so that for error. In other words, if you have a very elastic lesion or very calcified, this thing should be able to oppose the elastic recoil. And so I thought that in plastics was a terrible idea because they have much, the values, no matter how you look at them, they're so much lower than metals that, the elastic recoil is going to be a problem. So when I was seeing the trials and the thing of the massaging of the stent and balloon dilating forever until finally it stays in place, I thought the amount of trauma that you're going to create by doing that, you're going to counteract any beneficial effect. In other words, restenosis. But at any rate, I never liked the idea of the bioresorbable stent, and I was lecturing against it, even during its bright days.
Was the recoil determined by the metal or the architecture of the Palmaz ring?
Well, it's both, actually. It's both. Obviously, the lesion has an inherent recoil, isn't it?
Right.
And so even normal artery has, a fair amount of recoil just because of all this architecture and everything else. But then when you have the calcium on top of that, you have more complex issues there, the asymmetrical expansion, the fracturing, the delamination, and things like that. So obviously the metal scaffold needs to, for one thing, scaffold. The second thing needs to be opposed, radial forces.
Right. But the expansion from A to B, as you say, somebody's got to figure out how to lock that open when it's open.
Well, at the beginning, we were limited by the technology.
Yeah.
So, we were getting expansion ratios of 1 to 3 at the beginning, meaning that you could only dilate it 3 times over, the initial undeployed diameter. Today, we have 8, 9.
Yeah.
It's incredible,
amazing.
And the radial forces are magnificent. Even, low profiles and things like that. Things have progressed enormously.
Hadley?
Yeah. Thanks for being here. I mean, you just show amazing perseverance and drive. I mean, it's just admirable. So you also talked about the many obstacles along the way. So did you ever think about giving up or maybe just to heck with it and going in a different direction, something else, a new device? Did you ever think about giving up?
Yeah, 2 things helped me. For one thing, I got lucky, I mean, the right people came to my help, at the right time. And second, I always approach it from a negative viewpoint. That helps enormously because you don't get disappointments, and you get rid of that horrible thing, which is the positive bias. If you want it to work and you're really thinking that it's going to be the best thing after sliced cheese, you're done. So that helped me a lot too. And I always tell the young investigators, always approach it negatively, and it'll serve you well. But perseverance is, that is there, it's the most important factor. You got to stay, The idea in my case was 78 to a product that eventually got approved in 91. So it's many, many years. and you get just to stay there and keep doing it. So it's better if you have a day job.
That was very stimulating.
Yeah, thank you.
So we have few minutes, so we'll let everybody get to dinner and stuff. So for those of you that have not been to Palmaz Winery, it is an engineering marvel in and of itself. So who brought was that your idea to bring the engineering?
Well, here I'm conflicted, you realize. No, again, it was a group of people, And,
but you must have.
No, I was only part of a group, The idea was developed by committee, about the vertical. Yeah.
Architecture of the.
Yeah, engineers. Yeah, more than anything, engineers. Yeah.
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 Well.
Yeah, and geologists.
If anybody in the room has not been, you gotta go see it.
Yeah.
So, one last question. I just when you talk about luck, you had mentioned something maybe last night or previously about the Romano. How did he get into the crew? Didn't you meet him, or did
Romano and Richard met by playing golf?
That's what it was.
And I think Richard explained to Romano the idea of the stent over a napkin in the water hole after the game.
But they just met playing golf, just happenstance relationship, and started talking.
Yeah, and I was at home. I think it was a Sunday, and we just had that thing about the baboon dying. Okay, I mean I got to get again to another story. So, when we were planning to do the first coronary stent, Richard had the bad idea to use a baboon as the first animal. And it was a smoking baboon at that. Yeah, the Southwest Research Foundation had the colony of smoking baboons, and these monkeys were very expensive, and but Richard, pushed into using that as our first subject. And when we interviewed the baboon, I mean, he looked very human to me, I mean, this guy who was smoking, by the way, it was eerie, tell you the least. So we did the baboon. We left, it was successful placement, and we left. I mean, we used heparin. That's the only thing, and we didn't even check the ACT. We just
put it. That's correct.
Theoretical amount. 2 hours later, the baboon was dead, and so we were on the way back to San Antonio from Southwest Research, and we got the call, and we went right back, and the veterinarian there in charge of the colony, he said, "Guys, I trusted you, and look at this. I mean, you killed the $5,000 baboon." He said, "Well, I mean, regardless, it was a shock to me, And I said, "Richard, this is a signal, I don't like this, And he said, Richard was always very, cut and dry. He was said, "You know what? The baboon is the wrong animal." He said, "We're going to use dogs." And I said, "Richard, which dogs?" And said, "Yours." I had a small group of dogs that were all implanted. He said, "Yeah, but the coronaries are clean. Yeah, we'll use them." And fair enough, we did the 12 animals that we had. We all implanted all of them, and we started doing angios and controls, and eventually we got autopsy specimens and all that, and the paper got published in Circulation. And so...
Did you start using heparin on the dogs?
Yeah, right. At that time, we started doing ACT. Yeah, finally.
That's interesting.
And yeah, it was great. We even with the histology of that group of dogs, we were the first to detect that there was a shrinkage of the neointima that formed over the stent. So it peaked at 3 weeks, and then it will start going down by scarring. So, and so we published that. And
was there any predictor of restenosis at that? I guess it was too early in the
no,
sacrifice.
the way around. Not only we didn't know about restenosis. I mean, the results were fabulous.
Yeah.
All the dog corner is, the lumen narrowed and then opened up again, and so it was, really promising at that time. Really promising. All endothelialized. We learned how to cut stents using diamond saws, so we had beautiful specimens. Yeah, it was a great study.
That's fabulous.
Yeah.
All right, well, we'll let everybody get on to their evening activities. But thank you again, not only
Thanks
for being
listening
a
to this old
part of this
story.
meeting, for your time.